Hey, kid. How you boys doing?
Hemochromatosis is caused by autosomal recessive mutation in the HFE gene, which encodes a production of hepcidin. With mutation, the production of hepcidin decreases, which leads to a massive increase in iron absorption. The accumulation of abnormally high amount of iron in the body we call iron overload, which is the signature feature of hemochromatosis. It's also important to mention that iron overload can develop secondary to chronic transfusion therapy, such as in patients with severe thalassemia. So, how does decrease in hepcidin production leads to iron overload, and how iron overload affects our body?
Listen, everybody, be calm, cooperate, and this will all be over in a minute.
So, when we consume some iron with diet, iron in comes into the small intestine, where iron undergoes absorption. Iron absorption is provided by a specific protein called divalent metal ion transporter. And we have to know that the function of divalent metal ion transporter is regulated by a specific protein called hepcidin. Hepcidin inhibits the activity of DMT, and by this we can regulate the amount of iron molecules that come to our body. In turn, the production of hepcidin is regulated by HFE gene, which is located on chromosome 6. Once iron is reabsorbed by intestine, iron leaves enterocytes through the ferroportin and enters into the blood. In the blood, transferrin immediately binds to iron with formation of iron-transferrin complex, and in this form, transferrin delivers iron to liver tissue. Once iron enters into the liver tissue, ferritin immediately binds iron with formation of ferritin, and in form of ferritin, we store iron in our organism.
Pretty smart, huh?
Pretty smart.
But in hemochromatosis, mutation in HFE gene occurs, which disrupts the production of hepcidin. With decrease in hepcidin, DMT transporter becomes disinhibited. With increase in activity of DMT transporter, the absorption of iron dramatically increases. This leads to a high amount of iron entering the blood. So let's suppose that 2 extra iron molecules enter into the blood. And recall that we cannot transport iron through the blood without transferrin. And if previously we had 3 transferrin molecules per 1 iron molecule, which gives a normal transferrin saturation of 33%, now we have 1 iron molecule per 1 transferrin molecule, which gives transferrin saturation of 50%. So increase in income of iron into the blood results in increase in transferrin saturation, which is the first diagnostic marker of hemochromatosis. Obviously, with increase in amount of iron in the blood, the level of serum iron increase, which is the second diagnostic marker of hemochromatosis.
Pretty smart.
Yeah, I got my moments.
Additionally, with increase in amount of iron in the blood, the delivery of iron to the liver tissue increases, and in the liver tissue, ferritin binds all free iron it can with formation of ferritin, and ferritin is the major storage form of iron. So, with increase in iron delivery to peripheral tissues, the level of ferritin increases, which is the third diagnostic marker of hemochromatosis.
Is that a fact?
No, it's not a fact. It's just what I heard. It's just what I heard.
Who told you?
They?
The problem here is that we have a limited amount of ferritin in the body, and such massive income of extra iron overwhelms the capacity of ferritin, which results in accumulation of free iron in the tissues. But what is the problem with free iron? I think you already noticed one interesting thing about the iron. Once iron comes to our organism, iron practically never walks alone.
I don't know. That's a good question.
The reason is that iron is a lighter, and water combined with oxygen is a gasoline. And as you know, we have a lot of water and oxygen in our organism.
But still, I have to say, you play with matches, you get burned.
What do you mean?
The problem here is that iron in a free state reacts with hydrogen peroxide, and we know that hydrogen peroxide is formed from water and oxygen. This reaction we call Fenton reaction, and as we see, the final product of this reaction is hydroxyl radicals. Hydroxyl radicals belong to reactive oxygen species, which means that they are extremely dangerous substances. So, accumulation of free iron in the liver results in massive production of hydroxyl radicals that cause severe oxidative injury in the liver tissue. So, initially, hepatitis develops. With inflammation in the liver tissue, hepatocytes die and their internal content begin to leak into the blood. So, death of hepatocytes will cause increase in ALT level, increase in AST level. Also with inflammation, the size of the liver will increase, so hepatomegaly develops. With time, chronic liver injury leads to a formation of cirrhosis, and cirrhosis can be complicated by liver cancer. We call this state hepatocellular carcinoma.
That's a damn shame.
But liver is not the only organ where free iron molecules begin to accumulate. Free iron molecules begin to deposit in the joints, where progressive accumulation of free iron molecules cause arthropathies, arthralgias, and chondrocalcinosis. Also, free iron begin to deposit in the skin, where it causes hyperpigmentation, which is one of the hallmarks of so-called bronze diabetes. Deposition of free iron in the heart results in development of cardiomyopathies, usually restrictive or obstructive. Additionally, free iron begin to deposit in the pituitary gland, which results in hypopituitarism. And hypopituitarism leads to hypogonadism. And last but not least, iron begin to deposit in the pancreas, where free iron molecules cause severe pancreatic injury, which leads to a diabetes mellitus. And diabetes mellitus is the second component of so-called bronze diabetes.
What's your thoughts on how to handle this?
What's yours?
Here we can see a diagnostic approach from the recent guideline on hemochromatosis. So, if person has classic hemochromatosis symptoms, as arthralgia, chronic liver disease, and diabetes for example, in this case we check his iron panel. And if iron panel shows increased transferrin saturation and increased serum ferritin level, it's highly suggestive of hemochromatosis. So in this case, to confirm the diagnosis, we check for a mutation in HFE gene, which typically causes this disorder. And if mutation is positive, then it's classic HFE hemochromatosis. But if mutation is negative, we are trying to examine the state of his liver tissue on presence of iron overload. And if iron overload is present, then we check for other hemochromatosis-related genes. Iron overload with absence of classic HFE gene mutation we call non-HFE hemochromatosis.
You know what I'm saying?
It's an interesting point. Come on, let's get into character.
So let's summarize. Hemochromatosis causes severe iron overload. In this state, iron begins to deposit in various tissues. Its liver, pancreas, skin, heart, pituitary gland, and joints. in liver tissue, deposits of iron can be identified by liver MRI, or deposits of iron can be identified by liver biopsy with Prussian blue staining. Typically, hemochromatosis presents after the age of 40. The reason is that it takes time to accumulate such significant amount of iron to cause some serious clinical symptoms. Hemochromatosis manifests with classic triad of cirrhosis, diabetes mellitus, and skin pigmentation. Together, diabetes with hyperpigmentation we call bronze diabetes. In addition to this, hemochromatosis causes restrictive or dilated cardiomyopathy, hypogonadism, arthropathy, and hepatocellular carcinoma, which is the most common cause of death in these patients. The first-line treatment is phlebotomy, because with loss of blood we lose hemoglobin, and hemoglobin contains iron, so by this we can decrease the total amount of iron in the organism.
Check out the big brain on Brad. You're a smart motherfucker, that's right.
In addition to this, we can use iron chelation agents as deferasirox, deferoxamine, and deferipron. The concept here is that if we prescribe deferoxamine, this agent comes to the blood and tissues where it binds free iron molecules with formation of a stable complex. So by this, deferoxamine can neutralize free iron molecules, which can prevent iron-mediated damage. So here we can see treatment approach from the guideline. As we see, phlebotomy is the first-line option. The reason is simple. Phlebotomy has less amount of side effects compared to drugs. In addition to phlebotomy, we can use erythrocytophoresis. And as a second-line option, we can use iron-chelating drugs as deferoxamine. Here we can see a clinical case. It's a 34-year-old man. For the last 9 months, he had occasional discomfort in the liver. His aspartate aminotransferase was 48, which is practically normal. Alanine aminotransferase was 73, so ALT was elevated. Serum iron was 23, which is normal. Total iron binding capacity, also called transferrin level, was 47, which is slightly lower than normal. But the big deal here is ferritin level. His ferritin was 12,000, which is huge, and his transferrin saturation was 50%, which is above normal. They did MRI, where they determined enlarged spleen and extensive uniform decrease of the signal in the liver and spleen. And this feature can be explained by the deposition of metal ions inside the organs. This creates so-called black liver on MRI. They performed liver biopsy with Prussian blue staining, and as we see, they determined massive deposits of iron in the liver tissue. After this, they checked for a classic HFE mutation, but in this case it was negative, so it's non-HFE hemochromatosis. And as a treatment, low iron diet and phlebotomy every 3 to 6 months was prescribed. The reason why iron chelation agents were not given is because it was not a severe hemochromatosis. We do not see here massive increase in serum iron. We do not see here severe clinical symptoms. So in this case, phlebotomy and low iron diet were enough, and the patient remained asymptomatic with 5 years follow-up.
And?
And nothing. That's it.